In this tutorial, we're going to look at volatile anesthetic agents, the ones that we commonly use, isoflurane, sevoflurane, and desflurane. And I'm going to start with a review of some of the pharmacological aspects of these drugs, and then we're going to compare the different drugs and look at their physiological effects. Fundamentals of anesthesiology with me, Pat Nelligan. Understanding gases and vapors. Volatile anesthetic agents. Inhaled anesthetics are agents that produce anesthesia, that's amnesia, hypnosis, and immobility when delivered by the inhalational route. They are always delivered as gas, but they are generally separated into gases and volatile agents. A gas is an agent that is always a gas at room temperature. The example here is nitrous oxide. There have been other gases in the past, but this is the only one that we currently use, and realistically, it's not a full anesthetic agent. A vapor is an agent that is stored in a bottle as a liquid, and it is released as a gas from a specialized device that's known as a vaporizer. We call these volatile anesthetic agents. And for almost 200 years, most general anesthetics have been delivered using a volatile agent. The fact that these drugs are stored in liquid form has major advantages. A small amount of liquid can generate a large amount of gas. That liquid is stable, it can be kept in bottles in cabinets. If the lid on the bottle is kept tight and none escapes, they can be kept on shelves for decades as they're extremely chemically stable. The bottles can be moved from place to place without any concern. They can be used in the battlefield, they can be used in hospitals, they can be used anywhere that you have the right equipment. In this tutorial, I'm going to look at volatile agents. I'm going to start with some basic principles about solubility, potency, minimal alveolar concentration, and the emergence characteristics. And then I'm going to look at the pharmacological and physiological properties of various agents. Let's start with the basic principles. We use the term gas to describe a substance that exists as gas under normal conditions, that's room temperature and room pressure. Hence, oxygen, carbon dioxide, and nitrous oxide are gases. A vapor is a substance that is usually a liquid under normal conditions, but gas escapes from the liquid at that temperature and continues to do so until the liquid boils and the substance becomes fully a gas. Examples of this, of course, are water, but in this tutorial, we're looking at volatile agents. A term that you'll encounter is the vapor pressure. The melting point of any substance is the temperature at which the substance changes from solid to liquid, and the solid and liquid phase exist in equilibrium. That's 0 degrees Celsius for water. When a liquid melts, gas is released, and that gas applies a pressure on the surface of the liquid known as the vapor pressure. And that's what we're working with when we're using volatile agents. This is the typical pathway for a volatile anesthetic. We fill the vaporizer up, for example, with sevoflurane, and then we take away the bottle, of course, and we deliver a fresh gas flow that carries the gas to the patient, to the patient's brain, and then the gas flows around the circle. Carbon dioxide is scrubbed out of it, and then it recycles around this circle system. It's very efficient, and the result is that the gas that we use to induce the patient may stay in the circuit for a very, very long period of time. Volatile anesthetics are delivered by the inhalational route via an airway. You can either hold a face mask, insert a laryngeal mask, or an endotracheal tube, and that gas enters the alveoli, from whence it goes into the blood. The blood then transfers it to the brain, where most of the anesthetic effects that we are looking for occurs. The agent passes in and out of the brain and is returned to the blood via the venous side of the circulation. It runs back into the lungs. Eventually, everything is in equilibrium. The dose of volatile agent that is given to the patient equals the amount of volatile agent that's coming out of the patient. We call that steady state. There are three properties of volatile agents that you need to know. The first is a thing called the blood gas partition coefficient, and this refers to the solubility of the agent in the blood. Most importantly, the less soluble the agent is, the more rapid the onset of action. The second thing is the potency of the agent, the oil gas partition coefficient, although most anesthesiologists use a different term, the minimal alveolar concentration, as their version of this measure. And the third thing is the tissue blood partition coefficient, the solubility in tissue and fat. The more soluble the agent, the slower the patient is to wake up. The blood gas partition coefficient is the most important of these. The lower that number, the blood gas partition coefficient, the more rapid the onset of anesthetic. Most anesthesia trainees at the beginning struggle to understand this, and I'm going to try and keep it very simple. With low blood gas solubility agents such as sevoflurane or desflurane, the blood behaves like a thin pipe. It cannot hold many anesthetic molecules, so blood concentration remains low. Partial pressure rises quickly, and this partial pressure is rapidly transmitted to the brain. With high blood gas solubility agents, the blood behaves like a large reservoir. It can absorb substantial amounts of anesthetic molecules. Blood concentration becomes high, and this delays the rise in brain partial pressure, so the patient is slower to go asleep. What we want to see is alveolar partial pressure rising as rapidly as brain partial pressure. And remember, the gas is going around in a circle. As the inspired concentration reaches the alveolar concentration, then anesthesia is accelerated. The higher the oil gas partition coefficient, the lower the concentration of agent required to achieve adequate depth of anesthesia. Now, most anesthesiologists don't use the term oil gas partition coefficient. They use an alternative term that was generated in the 1960s, and it's known as the minimal alveolar concentration. It's a surrogate term. The MAC is the age-adjusted expiratory concentration, not the inspired concentration, at which 50% of patients will not move in response to a surgical stimulus. It's usually anchored at the age of 40, but it does vary. Older patients have a lower MAC, younger patients have a higher MAC. A MAC fraction of 0.7 is the lower limit of acceptability to ensure absence of awareness, but patients do not wake up until the fractional MAC is below 0.4. The MAC is not a vaporizer setting. However, initial dosing on inspiration of volatile anesthetic is usually a multiple of the calculated MAC for that patient, so that adequate depth of anesthesia is achieved. When we talk about MAC, though, it is in expiration, end tidal gas. The initial dose of volatile agent is usually twice the age-adjusted MAC. The administered dose falls then to about 1 times the age-adjusted MAC at the beginning of surgery, and when steady state arrives, where uptake of volatile agent equals release, we settle at 0.7 of the age-adjusted MAC. This can be quite confusing because initially we look at inspired concentrations as we overpressure the system to achieve high exhaled concentrations in the region of 1 MAC at the time of intubation, and then dialing that back as the case goes on. At the end of the case, the patient will emerge from anesthesia once we discontinue the volatile anesthetic agent, but the speed of emergence is determined by the tissue blood partition coefficient. The higher the tissue blood partition coefficient, the slower the emergence from anesthesia. Patients wake up at a lower fractional MAC than is required to go asleep, and this is known as hysteresis. At about zero point 0.4 of a fractional MAC, the patient may open their eyes and obey commands. However, they do not retain memories until that falls below 0.25 of a fractional MAC. Remember, the patient may well move at a higher level than this. So at the end of the operation, the volatile agent needs to be turned down aggressively. Now let's see how this works in practice. This is a general anesthetic of a 40-year-old getting intermittent positive pressure ventilation with sevoflurane. On the x-axis, we have the different times of the operation: induction, intubation, incision, maintenance, closing, and emergence. You'll note that we have 2 y-axes. On the left, we have the inspired concentration of sevoflurane. On the other y-axis on the right is the fractional MAC. Remember, that's always in expired gas. We induce the patient with propofol, and then immediately set about attempting to ensure that there is sufficient volatile agent on board to make sure that at the time of incision, the expired concentration is about 1 MAC. So generally, most anesthesiologists will give an inspired concentration that's about twice what the MAC is for that patient's age. Then the vaporizer is turned down so that in multimodal anesthesia, the fractional MAC is about 0.7. Towards the end of the case, the vaporizer dose is reduced further to allow the volatile agent liberate from the tissues. There is a delay in the fractional MAC falling in line with the vaporizer, as this represents liberation of tissue-bound agent, and it's determined by the tissue-blood partition coefficient. You can see the divergence of the green line for the inhaled concentration and the red line for the exhaled concentration. The fractional MAC should be about 0.4 at the end of closure. The patient will remain unconscious due to hysteresis. Many anesthesiologists will add nitrous oxide at this stage to balance MAC and to accelerate emergence using the reverse second gas effect. Now let's look at specific volatile anesthetic agents. If you recall from our previous discussion how we got to here, I discussed old anesthetic agents, ether, halothane, and methoxyflurane. Now, these agents were very soluble in both blood and tissue, so there was a slow onset time and a slow offset time of action. Halothane was known to cause liver injury. Methoxyflurane, which was the first fluorinated ether, was highly metabolized by a factor of maybe 50%, and that released fluoride particles that were nephrotoxic, causing nephrogenic diabetes insipidus. And remember, the more soluble the volatile agent, the longer it remains in the body, giving the liver more opportunity to metabolize it. The currently available volatile agents were developed to minimize blood and tissue solubility, thus minimizing metabolism. These problems were resolved by adding more and more halogen groups to the base ether molecule, thus rendering them less soluble in blood and tissue. They're less metabolized and less flammable. By the 1990s, the de facto volatile agent was isoflurane because it solved most of the problems associated with ethers such as methoxyflurane and halogenated hydrocarbons such as halothane. Isoflurane is highly insoluble in blood. Its blood gas partition coefficient is 1.4. In comparison, ether and methoxyflurane have blood gas partition coefficients of 12. So isoflurane is really insoluble in the blood. It's also quite potent, requiring only 1.17% to achieve 1 MAC in a 40-year-old. It has modest tissue uptake and very low metabolism. So at the time, it appeared that isoflurane was the perfect anesthetic agent, but there was one major drawback, and that was that it was very pungent to inhale. In the 1980s and early 1990s, when isoflurane was still our go-to anesthetic agent, we used to have to use halothane for inhalational induction of anesthesia. Desflurane was the natural development of fluorinated ethers. The remaining chloride molecule was removed and replaced with fluoride. That made desflurane the most stable and least metabolized volatile agent ever produced. It does have a major limitation though. Its boiling point is 22.8 degrees Celsius. It boils at room temperature. So it required a special vaporizer, in this case the Tech 6 vaporizer, but that is not a problem. Once the vaporizer was developed, the agent was perfectly fine. Desflurane has a remarkably low blood gas partition coefficient of 0.42. It is also extremely insoluble in lipid. As a result, the oil gas partition coefficient and the tissue blood partition coefficients are remarkably low. The consequence of this is twofold. First of all, the MAC of Desflurane in a 40-year-old is 6.6%. That is a lot of particles to be giving a patient. The vaporizer empties very rapidly if high flows are used. But there is a benefit of this. Because so little desflurane is sequestered into fat during the operation, when it is discontinued at the end of the operation, patients emerge rapidly from anesthesia irrespective of their body habitus. Also, because there is so little metabolism of this agent, it can be used for very long operations without the risk of renal injury. Once an appropriate fractional MAC has been achieved, this agent can be used at very, very low flow. But it is not an ideal agent for all patients because it is very pungent to inhale, and as a consequence, it is really not suitable for inhalational induction of anesthesia. At around the same time as Desflurane was introduced into clinical practice, another highly insoluble fluorinated ether emerged from left field to become the dominant volatile agent of the 21st century, and that is Sevoflurane. Sevoflurane is also highly insoluble in the blood. It has a blood gas partition coefficient of 0.65, so it's much less soluble in blood than, for example, isoflurane. However, it is more soluble in muscle and in particular fat than desflurane, and that means that patients will be slower to emerge from anesthesia when given Sevo versus desflurane. There's also significantly more metabolism, and this is potentially a problem for very long operations. So why is sevoflurane so much more popular around the world than desflurane or isoflurane? And the reason for this is because of pungency. Sevoflurane is a very sweet smelling agent versus desflurane and isoflurane, meaning that it is an ideal agent for inhalational induction of anesthesia. It has most of the physical properties that we associate with the ideal anesthetic agent. And while some patients, particularly obese ones, can be slower to emerge from SIVO anesthesia, the fact that this agent can be used in all patients all the time has resulted in it becoming the de facto agent of choice despite its highish rate of metabolism. Some clinicians also quote its less negative environmental impact versus desflurane as a reason for choosing sevoflurane. Volatile agents render patients fully anesthetized with hypnosis and amnesia, immobility, and they blunt the adrenergic response to a noxious stimulus, but they also affect many organ systems. So let's look at these sequentially. In the brain, volatile agents cause dose-dependent loss of consciousness. That's amnesia, sedation, and surgical anesthesia. Cerebral metabolic rate is reduced. There is increased cerebral blood flow due to cerebral vasodilatation, and that does increase intracranial pressure. Volatile anesthetics produce dose-dependent spinal cord depression, and this is really important. They cause immobility. Propofol does not do this. There is reduced nociceptive transmission, so reduced responsiveness to surgical incisions. There is reduced alpha motor neuron activity, muscle relaxation, and reduced autonomic reflexes. That means that they blunt hypertension and tachycardia, particularly at high doses once surgery has started. It's important to understand that suppression of brain activity occurs at lower doses than suppression of spinal cord activity. So patients may actually move while they are fully asleep. If your patient moves the surgical incision, you just need to turn up the dose of volatile agent. The patient is not awake. Volatile agents cause respiratory depression, and this is dose dependent. There is reduced tidal ventilation and reduced ventilatory responses to carbon dioxide and hypercarbia. As a consequence, the end tidal CO2 will go up, as will the PaCO2 and the pH will fall. This is not a big deal. It happens to all patients who breathe spontaneously under anesthesia, and it appears to have no negative consequence. There is a reduced response to hypoxemia, and these agents, particularly sevoflurane, are very effective bronchodilators. All volatile agents cause hypotension, and this again is dose dependent. They cause vasodilatation of arteries and veins, and as a consequence, mean arterial pressure falls. There is mild myocardial depression due to a reduction in contractility that reduces the stroke volume. The fall in the blood pressure does not result in tachycardia. As a consequence, these agents are seen to be vagotonic, but the heart rate does differ between agents. Sevoflurane may have no effect on heart rate or may drop it. Isoflurane and Desflurane, in particular, may increase heart rate. But the major effect of all volatile agents is to reduce blood pressure. So after you induce anesthesia, you give propofol, which is a vasodilator, and then you add to this a volatile agent. The patient's blood pressure will almost always fall. This is easily treated with a bolus of ephedrine or phenylephrine. In terms of the other organ systems, the neuromuscular blockade that you administer to the patient is potentiated by volatile agents. There is mild venodilatation, so the unstressed blood volume increases. And as a consequence, when you give fluid to these patients, that fluid is retained in the body for up to 2 days. There is reduced renal blood flow, and that's again caused by hypotension. If you give a vasopressor agent and restore blood pressure, the patient's renal blood flow is normalized and they don't retain fluid. There is mildly reduced hepatic blood flow, but this does not seem to be a negative effect. If the patient is, for example, an obstetric patient, there is dose dependent uterine relaxation. That is something you need to be aware of if you're giving volatile agent as a general anesthetic in obstetrics. And the agents may or may not have mild anti inflammatory effects. So there are lots of different effects of volatile agents on different parts of the body. And if you look at the three agents that we have, there isn't a huge amount of difference between them. In terms of airway irritation, there is no doubt that the least irritating agent to the airway is sevoflurane. Desflurane may cause the patient to cough, breath hold, and have laryngospasm, particularly when you're giving the patient a marginal inhalational dose of that volatile agent. Sevoflurane is extremely forgiving in this setting, and if the patient starts moving or getting mildly laryngospastic, if you turn up the dose, that usually breaks fairly quickly. Sevoflurane is the only one of these agents, in my view, that should be used routinely for inhalational induction of anesthesia. Also, it's a very potent bronchodilator. In terms of the cardiovascular effect, if a patient is at risk for myocardial ischemia, sevoflurane and isoflurane really have very little effect on heart rate. Desflurane can cause a mild activation of the sympathetic nervous system and increase the heart rate, particularly if you ramp up the dose very quickly. Sometimes this has the impact of maintaining blood pressure after you give desflurane. But you have to look at the clinical cases individually to see whether or not this is important to you or not. So that transient sympathetic stimulation may be a positive or a negative thing for your patient. They all cause coronary vasodilatation. They don't cause arrhythmias. That used to be a problem with halothane. Cerebral blood flow is increased in a dose dependent manner for all cases. And as a consequence, the intracranial pressure will go up. So if you're worried about high ICP, perhaps using total IV anesthesia may be a better option. In terms of emergence, there is no question that patients emerge from anesthesia quicker with desflurane versus the other agents. But of course, this is determined by the duration of the operation, what other agents you've given. For example, if you've given high doses of opioids, it's not going to make a whole lot of difference. If the patient is morbidly obese, they will wake up faster than if they're given sevoflurane. For most short cases, it doesn't make a lot of difference. And of course, all of them are suitable for low flow anesthesia. Let's review this tutorial. In this tutorial, we talked about volatile anesthetic agents and we looked at the solubility, potency, MAC, and emergence characteristics. the pharmacological properties of volatile agents and their physiological properties. I've only focused on isoflurane, sevoflurane, and desflurane because these are the only agents that are currently used in clinical practice. They're all worthwhile, they all have their uses in different scenarios. In a parallel universe, we never got sevoflurane or desflurane, and we're still using isoflurane, and we're perfectly happy with it. The reason why sevoflurane took over from isoflurane is not because patients go asleep quicker or wake up quicker, but because you could use it for inhalational induction of anesthesia. In the next tutorial, we're going to talk about how volatile agents are delivered. We're going to look at vaporizers. I'll see you then, and I guarantee you'll learn something.